Good morning, everybody. I'm delighted to welcome you all here today to our first session this morning, which is on rapid evaluation, tomorrow's world. My name's Jenny Newbould. I'm a research leader at RAND Europe, and I'm also part of the BRACE rapid evaluation team funded by NIHR. And obviously, as you'll all know, since the beginning of the pandemic, life has changed very much, but also research has changed a lot. And researchers worldwide have been under pressure to undertake evaluations to produce very timely findings. And in this session, we're going to explore how approaches to evaluation have changed as a result of this, what we've learned from recent examples from policy and practice. And we hope that you'll leave with a better understanding of how evaluators can better facilitate rapid learning, as well as how best to shape research priorities in the post-pandemic evaluation landscape. So I'm joined today by two really great speakers who I'm really looking forward to hearing their presentations today. And we'll have two 5-minute presentations, and then we've got a lovely 30-minute session for questions. So I'd really encourage you to share your questions, thoughts, comments in the chat box on the live stream page. And we look forward to hearing your questions at the end of the presentations. And I'm joined today by Matt Inada-Kim and Lucy Sandell, who are going to talk to us today. So Matt is the National Clinical Director of AMR, National Clinical Lead for Deterioration and Sepsis at NHS England, and also a consultant in acute medicine at Hampshire Hospitals. He has been in charge of developing and co-leading the virtual ward model and the COVID management guidance in all settings and evidence for the role of oximetry in patient groups. He's worked to improve patient progression in recognition, escalation and communication of the response to deteriorating patients. And he's going to talk today particularly about his work in COVID. And Lucy Sandell is a Senior Analytical Manager from NHS England and Improvement. And she's worked on the Medicines Optimisation in Care Homes programme and has a wealth of experience in planning and designing evaluations. So I'm going to pass over to you first, Matt, for our first presentation.
Thank you very much. Do you mind popping on the next slide? So really nice to meet you all, and thank you for joining today. As Jenny said, the bent of, I guess, all of our work within COVID going forward with how do we make things better was the question. And during first peak, clinicians like myself saw a lot of cases of patients arriving too late, essentially blue, with an absence of symptoms, this syndrome of silent hypoxia. So the question in the community, in hospital services, in ambulances, in care homes, in domiciliary care, in mental health, learning disabilities, was the same one. How do we make the situation better and generate hypotheses? And upon generation, how do we then prove the hypothesis and actually make a rapid evaluation within challenging circumstances to ensure that we better the healthcare system moving forward, and that these bits of evidence are shared widely. So the principles of what we aimed for really were about patient empowerment, self-monitoring, self-escalation, teaching people what to look out for, and empowering them with oximeters to be able to record their oxygen levels, so that we got to the heart of earlier recognition of deterioration, reducing unnecessary admissions where that's possible or probable, and improving the speed of discharge from the hospital end. And we had the help of a lot of people on the call: Birmingham, Oxford, we had UCL, Imperial, all really coming together to try and pull together the early evaluation on this COVID oximetry at home model, with very exciting early results in terms of reduction in overall case fatality rate, and in a lot of areas around the country, a reduction in admissions. It was all underpinned really by rapid early research that really proved a hypothesis. So the hypothesis was the lower your oxygen level at home, the worse your 30-day, 5-day, 24-hour prognosis, both for death and intensive care. So we brought together a really rapid evaluation group at Southampton, across South Central Ambulances and across My Acute Trust, to get the data sharing in place, to really look at the data, 2,000 odd patients, from generation of hypothesis to production of results within a 2-week period that also involved getting the necessary data sharing. And it was up on pre-publication within 3 weeks, shared 100,000 times across the internet with downloads on PDFs and looks and impressions on Twitter, leading to a huge altimetric score, but something that is still awaiting publication because of, I guess, the speed of publication in relation to what we are all using, which is pre-publications and Twitter at the moment. So the data and the evaluation was amazing going forward. We've had incredible results from acute organizations who've all listed their results on whatever social media there is, and in some cases published it within journals. But to be quite honest, a lot of this is going via social media. We do not have the time to wait for journal publications. You know, this is too rapid and the lessons are too important. And indications and elements like inclusion criteria for who should be included in this protocol, how the COVID virtual ward operates is really important going forward. And the lessons from involving patients and carers in their own care, healthcare professionals, there is a rich tapestry of potential researchable and evaluatable evidence that's out there. And the question is how nimble we are as a group of potentially interested researchers within this brave new world. And the engagement with clinical teams is absolutely paramount to this. Right from the start, we've learned that we don't get anywhere unless that process is properly adhered to, because that's where all the intelligence is. It's not in a textbook. It's not in a room full of administrators. This is about the clinical front line and engagement with that. And the implementation of this process has really taken off from the 4th of December, when we got the national mandate, to the end of December, so a period of 27 days, led to near universal uptake of this project across the whole country. And the times are exciting for that reason. Next slide, please. To accompany that, a huge bunch of resources were produced: safety netting guidance, diaries, patient instructions, the oximeters themselves, of which there are now 700,000, the staffing competencies, the training materials and e-learning resources, as well as apps. Again, all stuff that needs studying, and rapidly so. Next slide, please. And in the future, what we hope to do is really tap into what we already have developed, this learning network of patients and healthcare professionals, all married to this aim of trying to improve the management of deterioration and COVID. And you're very welcome to join this. Ping me a request to join. There are nearly 1,000 members now, clinicians mainly, and leaders mainly, and academics. And we put all of the resources that are available together with comments and questions from the front line and to the front line. Including helpful resources about how to do it, essentially implement it, and what the evidence is. So this is very adaptive work, and this is the way we learn, you know, in today's worlds, the front line to the center engagement. Next slide, please. And it really harks to, I guess, what we're after, which is this nimble approach to evaluation that's really quite agile and very dynamic. We don't have the time to waste to go back to the old days and the ways of doing things. We often don't have time to waste for a publication. You know, this is about doing the best we can with imprecise information, to be honest, at times, from a policy perspective, doing the best decision-making that we can do with the best available evidence, but accepting that perfection is the enemy of the good. That is the way in a pandemic. And, you know, there are huge numbers of future questions that we will need to answer about this program that our wonderful teams are working on as we speak. This is a work in progress and nothing complete. So I look forward to future questions, and thank you for listening today. Thank you.
Thank you very much, Matt. That was really interesting. Look forward to some questions. I'm going to hand over now to Lucy Sandell, who's going to give our second presentation for us today.
Thank you very much. I'm really glad to have an opportunity to discuss this. Being part of a team at NHSEI that talks to a lot of programs and helps them plan their evaluations means that I've had a real variety of experiences. And obviously, while there's no universal experience and every program has faced different challenges, this is the sort of thing I've heard back. So next slide, please. So what kind of changes do we need to take account of? I think, firstly, in terms of resources, frontline staff are obviously under great pressure, and that means that there's less capacity generally for them to engage with evaluation work. And with the scale and speed of decision making, it's not really surprising, but we've had very high expectations put on us for what we can deliver in evaluation and very little time to deliver. In terms of methods, normally reliable methods might not work as planned. That's what we found in the last year. On the quant side, you could set up a new data collection for a new process, but you can't guarantee good quality returns at speed from stress systems. And on the qual side, while some qual work has been delivered and worked really well and helped the participants process what's happened, others have been set up and then ended up being cancelled because people can't take the time. And in terms of disruptions, we don't know yet which of our findings will apply post-COVID and which are specific to this time and place. In terms of stops and starts to evaluations, that's made resourcing very difficult and keeping up progress very difficult. And for people with caring responsibilities, the disruptions have been on a whole different scale. Next slide, please. So to the future, we're in a relatively good place in terms of how evaluation's considered with this higher demand, higher profile. There's more acceptance than ever of things like process evaluation, the value of implementation evaluation, and of mixed methods. We're likely to be a long way off normal, though. For example, like time series data analysis could take a couple of years to get back to normal completely. And when will staff mental health be normal, or care home numbers? So my feeling is that we need to work out evaluation in the new weird before we even get to a new normal. So around agility, a couple of things occur to me. There's new skills involved in how to stand up a team quickly, work more quickly, and learn what you can compromise and what you can't. And we had some really good, useful advice on that from previous speakers, such as on Tuesday, looking at don't skimp on scoping or comms. Theories of change can change very fast, and there's a lot of difficulty in trying to keep up with what theories of change are changing through a program. And also additional client focus, because agility requires a lot more trust on both sides. So there's a lot more ongoing discussion, a lot more ongoing communication to help keep up that. In terms of returning to check, where we've done more provisional work and we had to do what we could within the timescale we were given, there might be important to remind people that we need to go back if they're going to rely on that information in the longer term. There's lots of things like data collections been set up, but after the fanfare, are we going back and checking whether it's still needed, still useful, still in the right format? And also returning to check to up our ability to understand health inequalities, to reflect the consensus on the importance of that. And it's kind of sad irony that we've not had as many opportunities because of the speed of our work to raise the voices of the harder to reach, just as there's been more consensus that we need those voices. In terms of innovation, there's lots going on, but two things that I've noticed is participatory research is back. That's quite exciting. Voluntary data collections. And one of the things that occurred to me last year was that there was a relatively limited set of methods being used in rapid cycle evaluation. And we felt as a team that was because isolation makes experimenting a lot harder, which is one reason why we set up our community of practice last year. So if we go on to the next slide. So for example, I'm really interested in learning more about QCA, which is a qual technique, but being able to experiment on that without having some ability to check in with other people is tricky. So on a grey day in what feels like the 15th week of January, it might be quite hard to see, but my feeling is that we've got knowledge and we've got specialist skills and we're in demand. So we have an opportunity here. It's, the opportunity of crisis to stitch a new future that fits evaluation needs better and raises those unheard voices and creates new insights. But we'll need to talk to each other more to create something that works. So I'd invite anyone who's interested in evaluation to join the community of practice that we've got going. And last thought would be, we're evaluators, So let's be purposive about planning the future. What does a good evaluation future look like? Does this current project lead to it, or is it moving us away from that? What can we build on? What should we let go of? So I'd leave you with the thought, what would you like the future to look like?
Thank you, Lucy. That's a nice thought. What would we like the future to look like? Maybe seeing other humans and having a cup of tea might be one of the things on our mind this morning.
Lovely.
So thank you very much, Lucy and Matt. I look forward to taking questions. Some really interesting insights there, and I'm sure lots of the researchers and clinicians who are joining us this morning are reflecting on how those processes have affected us, our work ourselves, and also the research that we're doing. Particularly the stopping and starting resonated with me with some of the work that we've been doing over the last year. So my first question to you both really is, what do you think we've learned from COVID-19 about conducting research rapidly? If I asked you kind of one thing that you think has been the biggest thing that we've learned due to this rather strange times. Lucy, any reflections from you?
Lots actually. Yeah, I think it's really focused us on what we're trying to do and how you decide to do a particular kind of evaluation. So things like, how do you decide the size and scope of what's needed? Like working out what scale of decision is going to be relying on that information. How quickly do they need it? The likelihood of harm or health inequalities being exacerbated by the intervention, and the kind of adaptability that's needed. Like, do we need to make sure that our findings work for everywhere, or is it just checking this particular area? Those kinds of things. It really focuses us down on what do we absolutely need in order to deliver something useful at speed. I think that's a real focus.
No, that's really interesting. Thank you, Lucy. Matt, any reflections from you?
So I've enjoyed the lack of barriers. So from a governance perspective, as you say, we were able to turn around NRHR approval within 36 hours, I think was our record. Everyone was falling over themselves to really help, although the processes were still pretty cumbersome for a clinician like myself. At least it was easier than it was. And I think the other thing that I've really enjoyed has been the collaboration elements to really get things underway. There isn't been the jealous guardedness of information or data in the hope of getting a publication out that we generally see in life. It's just gone out of the window, I guess, with COVID. And again, it's something that I hope we can build on, because what I've noticed from that is that people that share stuff and share things widely and generously are always really accredited with the idea, because people will always refer to them as where the idea came from. And at the end of the day, that's for the greater good. That's absolutely what we're about. So I hope that spirit of generosity and sharing translationally across all organizations can continue going forward.
Absolutely. Fantastic. We've got some questions from our audience. This is from Martin Clark, who's from the Nottinghamshire Healthcare NHS Foundation Trust, who says, please can you say something about your experiences of getting approval for rapid evaluations, HRA processes, ethics, etc.?
Well, I'll duck out of that side because that isn't something that I've been greatly involved in. I've been helping other people plan their evaluations, so that isn't so much my side of things. I'll pass over to Matt.
Matt, you mentioned, didn't you, that the governance had been a bit easier than it might otherwise have been? Yeah,
I mean, to be honest with you, so the times I've been involved, and there hasn't been a huge amount that I've directly been involved with, others in the team have been doing all of the heavy lifting here, but the times that I have been involved with, it's really been a case of emailing the right person or picking up the phone and having a 10-minute conversation. And what has constantly surprised me is the can-do attitude, quite honestly, across all sectors, not just research or evaluation, but across the wider NHS and the supporting structures. And that can-do-ness is an infectious element of all of this. So suddenly, instead of the 3-month wait, it was literally 36 hours. And these are interesting times. I think the ability to have that one-to-one conversation with someone in a different department, potentially in one that can say yes or no, and empower or allow your study to happen. And if they see the logic of it and the passion burning behind your eyes, it generally happens. And there isn't. The other thing that I would say regarding those applications is the meritocratic element of this is to some ways gone out the window. In terms of, I guess, convincing people that need to be convinced and to support your project. People are really looking at the quality of the idea more than they ever have done, rather than track record and whether you have a professor title behind your, in front of your name. And that is, again, something that I think has been a remarkable change. We are, I guess, less going for age and experience and going more for excellence and novel ideas. That's the world we're in.
That's really interesting. I've got a question for you, Matt, which is from a fellow acute physician, Nicola Irvine from the University of Strathclyde. And she's asking about ethical approval for the virtual monitoring and how it unfolded. But she says that as a fellow physician, few of my colleagues understand the necessary steps to ensure data that we have at our fingertips is managed respectfully and legally. Or if they do, they are put off by currently available processes to ensure ethical issues are addressed safely and rapidly. Is there an appetite for setting up local systems to approve, overseen by national bodies such as the HRA?
I mean, the way, I guess, what we did pretty early on and was important for our clinicians who had all the brilliant ideas, quite honestly, was ensure they were in a trusted research environment with academic partners who guided us through the difficult elements of ethics from a clinical perspective, at least, and data governance perspectives. And getting those signed off early was really critical. We had several stabs at it. So I'll never forget the first one. I was myself filling it in very badly, essentially to try and get this data sharing agreement across an entire region covering a 2 million population. You can imagine how badly that went as a clinician. But what it showed and what it allowed, and I don't regret the time I invested in trying to do this, was that it showed the intent and the passion to our universities and our departments that could help, and my own trust that could help more, and I guess the other supporting organisations who then really pulled the fingers out to actually do it. I guess because they could see the value of the research and the question that was being asked, but also because they could see someone who was really floundering in a world they had no expertise in, and realised they could really help. And these are the, it's a pity kind of thing, isn't it? But people did pull out all the stops. When they see the passion burning behind your eyes, they do. So, I think Nicola's right that we're jobbing clinicians such as myself are not very good at doing the data governance elements or indeed the ethical research applications. We need to find very quickly who experts within our regions or within our networks that are, and beg for help.
No, that's really interesting. I think those of us that are researchers sometimes feel that we're not professionals in ethics and HRA applications as well. So you're not alone there, Matt. One of the questions has come in from Sam Hinks from NHS England and Improvement. How do we maintain some of the facilitators to rapid evaluation that COVID has provided? Lucy, I'll ask that question to you.
Well, I'm going to say my community of practice. I think that's a great way of doing it. It is about maintaining momentum. If you can get something going during a time of crisis and then plan to embed it, then we've got the chance of creating a new set of realities of how evaluation should work and what we should expect it to look like. I think if we look at even if we put it in the context of planning for future emergencies, thinking about reviewing what went well and what didn't go well this time could help put us in a good place to have things like standardized ways of communicating across regions, standardized ways of understanding research needs and building that capacity into the system, standardized ways of having embedded trained researchers within local systems who have access and can take part. And all those sorts of things where we've managed to do in individual circumstances in a crisis. But if we can prove the case and embed that, then that creates an entirely new way of working that we can create for ourselves.
It's really interesting. Thank you, Lucy. Nicola Irvine, who posed that question to Matt earlier, says it would be great to this in-house for the work that goes on and lies in filing cabinets unused. I imagine there's lots of clinicians who are in that situation. We've spoken quite a lot today about that sort of spirit of collaboration and how these really challenging times have kind of brought different research teams together in helping each other, and indeed clinicians and researchers alongside each other, as Matt mentioned. And Joanna Scott from the Health Foundation asks, has the spirit of collaboration started to fall back? If yes, what do we need to do to sustain it for the longer term? Two-part question there, I guess, is whether that collaboration is receding and how we turn the tide.
I haven't noticed it falling back. And my simple answer to how do we stop it going back to the bad old days is not accepting that. Essentially, it's all about, I think, momentum and getting the room. And if 9 out of 10 of the people involved are interested in the new way of working, for want of expression, then we're not going to tolerate going back to a more sluggish environment. And we're noticing the same in policy and improvement, and I guess clinical sharing of protocols, etc. We don't want to go back because we cannot afford to go back, because we've learned there is a better way. The one upshot from COVID, if there is an upshot, has been that collaboration and that spirit of togetherness and doing things at speed and pace, and potentially not going through our traditional channels. We have evolved far beyond our old static models, and I think if we ever go back, the people that go back will be left behind.
Yeah, absolutely. Lucy, any reflections from you on that?
Yeah, I haven't noticed it falling back yet either, but I think, keep remembering when we're working at speed, it can feel like you're powerless, like you're just, on a juggernaut and you haven't got control, but we're a limited and specialized resource that's in demand. So we have the capacity to set our boundaries and to explain, and we've been explaining for years how, why these things are important, why it's worth, using mixed methods, doing process evaluation, not looking for impact within 10 seconds. All of those conversations, we know how to have them. We know the arguments. This is the point where, we can set those boundaries and say why. And like Matt says, not accept a slide backwards.
Absolutely. And it strikes me there's possibly two types of research that have happened during COVID. There's projects which maybe wouldn't have happened if it wasn't for COVID, and that have been able to rapidly regroup and start research and start collaborations. And then there's other projects, thinking of some of my work in primary care, where you just had to stop research that isn't very COVID related and pause that. And I just wonder what your reflections are on kind of the projects that have had to sort of stop and pause during this period.
Can I come in first on that one?
Yeah, please do.
Yeah, I think there's some projects where it really wouldn't have been any point trying to evaluate them, either because they just couldn't progress themselves in delivery terms, or because whatever we collected as information would be so specific to the era that it wouldn't be useful learning. So I think those ones, very sensible. But there's obviously been opportunity costs to focusing in. And I think this is the year when we try and work out what those costs are. And I pointed out one in my talk, which is, harder to reach voices and making sure health inequalities is at the fore. Speed sometimes makes that more difficult. So that now might be the time to try and catch up on ourselves in that sense.
Yeah, that's a really interesting point. I think engagement of challenging groups by its nature can be difficult in terms of time. If we're trying to find particular types of patients or particular types of inequality, it can be more challenging and time consuming. And also the patient voice sometimes is really valuable in research, but something that takes time to set up and consider. And I know isn't always something that we've been able to do very rapidly for some of the rapid work that we've done. That's really interesting. I have a question from Arnie Walters from the Health Foundation, who says, what elements of rigour have we lost in the transition to delivering linked data approvals and evaluation findings? I'm also wondering if operating at such pace is sustainable in the long run. Matt, any reflections on that point from your perspective?
So I guess I haven't seen the loss of rigour of data, simply because I guess the people behind the scenes have done all the heavy lifting, as I said earlier, to pull together what I guess clinicians or people not necessarily in this sphere 24/7 come up with into something that's tangible and doable and researchable. So I haven't noted that so much. I've seen an improvement in productivity and turnaround times, and it's an important question to understand whether the quality of that has suffered as a result. But I haven't noted it, I guess, in the projects I've been involved with. And what was the second part of the question?
Wondering whether operating at such pace is sustainable in the long run.
Yeah, so this is a good question that really relates to everything that we're up against. And the answer is probably no. We look to a time where we can relax, where we can take our foot off the accelerator in clinical care, in leadership and in research. And the truth of the matter is we need a more mature approach to what our endeavours are within research, within evaluation, within clinical practice and within leadership. We need to be able to be planning for the long term within this. But the compromise of it is to not fall back on old and bad ways of working in terms of the delays in getting stuff out. So I think there is a middle ground to be found between the rapidity of what we've seen in recent months with enforced by COVID against, I guess, going back to a more old-fashioned pace of working. We can do a lot more in our days productivity-wise, but I guess we need to be mindful of the impact that has on our physical and mental health and the sustainability of our projects. So it's maybe finding that middle ground of 75 to 80% and accepting that, and maybe taking our foot off the accelerator and not chucking away at 150% at all times, which is currently what we're all doing, I think.
Absolutely. Lucy, any reflections from you in terms of the element of rigour that we may have lost?
What gets compromised? Detail of analysis, number of time points, scope of sources. Those are a couple of things I noted down. And I think if anyone's actually studied Agile as a methodology for working rather than just a descriptive word, it's really key that there is empowerment of teams in that. And there's really key that between rapid decisions, there are periods of stability where people can deliver. So I think my reflections on agility is that we need to account for that. And especially given the disruptions of caring responsibilities, we need to make sure we leave space for people with caring responsibilities, and we don't give all the opportunities to people who can drop everything at no notice and work all the weekends. Because as groups, we know that we make better decisions when we have a diverse input from people. So we need to make sure our agility doesn't compromise that.
Absolutely. That's a very valid point about availability and the people who have caring responsibilities. And I just wondered about some of the downsides of having to evaluate things rapidly. I mean, the kind of the buzz and the momentum and the excitement kind of have kept lots of this research going within Brace as well. But our own experience has shown during COVID that some things are possible, but also there are limits to that kind of rapid working. And I just wondered if you had any reflections on that.
Well, from my point of view, one of the biggest issues is when programs are changing rapidly, the theories of change are changing along with them, and it takes an awful lot of resource to keep up with that, and to make sure that what you're evaluating is still what they're doing, and that what your methods that you're trying to use to understand it are still relevant given any changes in the program. That takes a lot of resource.
Absolutely. And Louise Snitch from NIHR has asked a very pertinent question, actually, which is the issue of which Matt brought up about publishing via Twitter and social media. And she asks, does publishing rapid evaluations via social media rather than in journals mean the peer review assessment of methods and results is missing? How do we address this? Perhaps one for you, Matt.
Yeah, no, it's a good question. I think if our peer review processes from most of our journals was as rapid as it potentially needs to be, it wouldn't be so much of an issue, but it isn't. And it isn't for a variety of reasons. It's not the journal's fault solely. There are huge mitigating reasons for why things are so incredibly slow in terms of publishing. That's why everyone's going with prepubs, quite honestly, in Twitter. And because this is information that is critical for patient care. And it's an evolution of, I guess, the future of research for that reason. If you see something published on Twitter by pre-published on Twitter by a respectable person with track record, you're going to read it. And you are going to evaluate things for yourself on the understanding that it hasn't been peer reviewed, because the people that read it actually do a lot of the peer reviews. So what you find is that it becomes an incredible research environment of actually to and fro about what the paper was about, what the messages were about, far more dynamic than what we currently have in our research environments, which are pretty old-fashioned. This is cutting edge discussion and to and fro about what you were trying to achieve with your research, held over an audience of millions of people. It is a very exciting and different world. And I guess the question is, do we move with the times or do we stick to our guns? And that might be my challenge back to others on the call.
And I guess that's the focus of this session, isn't it? Tomorrow's world, what will be the future be, and what direction will things go in? A question here about how we establish engagement with stakeholders who are willing to work with rapid evaluations and commissioners. How do we kind of bring others along on our research enthusiasm and project enthusiasm?
Well, can I come in on that one?
Yeah, certainly.
I think it does us a lot of good if we think about being very benefits focused. So, for example, I know of one program where qualitative work actually was really helpful in managing the stress of the people who were delivering the program by giving them a way to make sure that their learning wasn't wasted when they didn't have time to put that information together themselves. And so that was of a benefit to the people involved, and therefore it was successful all round, and it was helpful. And thinking of data as learning tools, so that you've got information that's there for them that they can use, and being that sort of, much more benefits focused, I think helps us in that situation. And just acknowledging, if we're working, that coalition of the willing is likely to deliver more ownership, more engagement, as opposed to saying, well, we're doing this quickly, so we're going to impose something, or we're doing it without you, we're doing it to you. We know, I think there was a really good example yesterday of how, you can have benefits from evaluation before you even get findings. If you've got people's ownership and buy-in, you're getting a lot more for your resources than you would do just by delivering.
Absolutely.
If I can come in, I agree with what Lucy's just said. I think there's an element of spin that I think we're not very good at doing sometimes from a research perspective, to actually ask the exam question in a way that actually appeals and is interesting. And this is an art form. It's how you write a business case. It's how you do your elevator pitch. And I'm unconvinced that we really nail this consistently. And that's the buy-in you get from clinicians who are incredibly busy working 150% already in patients and commissions. You have to have the message that really people really get and understand. And when you do, the barriers melt, and the positivity you get from the front line to engage in it really comes to the fore, and that's the opportunity to leap on. So partly there's a leadership thing, and partly there is comms and a messaging element. And one would argue that 10% of the time invested in that probably pays for itself 90 to 100 times over.
Yeah, absolutely. I want to just in the last few minutes just turn our attention to kind of the future of the evaluation world post COVID-19, and think about kind of how what the work that's been done on rapid evaluation during this period might have a legacy. And I wonder whether you think that COVID-19 has changed the expectations on speed of rapid evaluations, and whether people will ask, we did this before so quickly during COVID-19, why can't we do this now post-pandemic? Do you think there'll be a sort of, we've made rapid evaluation far more rapid during this period, and do you think that will be sustained?
I'm happy to have a stab. So from my perspective, absolutely. I don't think we're ever going to go back. We will not tolerate going back, quite honestly, because we've seen what you can do with evaluations. And certainly where I sit, 90% of the evaluations are about influencing national policy. So again, we do not have time to waste, going to official old channels. We have to get very quick answers. This is not the world we're in. And this is the blurring, I guess, between policy critical evaluations versus more cerebral evaluations for using more traditional research methods. And I guess going forward, we need to find a happy medium between the two. Both parties need to move. We need more robustness of what has been pretty large scale national decision making based on unpublished evaluation data, to one that is more rigorous, that has an element of peer review. But our publications and our research bodies need to be a lot more nimble than they are to help us on that journey, together with our evidence-based arm's length bodies. We cannot live in the 19th century. We have to move with the times.
Absolutely. And Lucy, any reflections from you on that kind of legacy of whether rapid evaluation will change sort of forever as a result of this?
Yeah, I think we've got the ability to push back, as I've already said. But I also think it's really, it makes coordination more important, because what we might be doing is small, brief aspects of something which, as a greater whole, can tell us something more reliable or can triangulate with other people's work. And what that means is that there's more demand on us to talk to each other and to work together and to make sure the sum of the parts is that we get a whole that's greater than the sum of the parts. So I think that's a very different way of working, but it's perfectly possible. I don't see it being necessary for us to just keep doing more quicker. I think we've got the ability to push back on that.
Yeah, that's really interesting. And so thinking kind of post-COVID into a post-COVID world, which is quite a nice thought to reflect on for a moment, what research priorities do we think rapid evaluation should be addressing when things get back to, I liked your phrase, Lucy, the new weird rather than normal, but if we can imagine a new normal for a moment, what sort of things do you think rapid evaluation should be focusing on?
Health inequalities. Sorry, Matt. You come in, I'll come in.
No, I think you probably nailed it. I mean, I have to say from what COVID has really showed a light on is different ways that healthcare can respond to the needs of the population. So I'd love to see more of that built upon. And, within my narrow field, that's about keeping people out of hospital who don't need to be in a hospital, exposed to all the dangers of healthcare, essentially, safely, and empowering patients and communities, particularly those with inequalities, really resetting that ballpark of what the public should expect of healthcare in the midst of a crisis, but also moving the ball on in the brave new remote monitoring, remote assessment NHS. We have seen, basically 20 years of change in the past 6 months in terms of how our model has evolved. And we are catching up from a research and evaluation perspective. We are far behind where clinical practice is. So what I would love to see is more engagement of those in evaluation and research, actually finding out what's happening with cutting edge clinical practice, and not, because it's a constantly changing arena, because that's the way things have to evolve. So reach out to your acute medical units where some amazing stuff is going on, your general practitioners who are thinking outside the box, your hot hospitals, your patient groups, your inequalities areas, and find out what's happening for yourselves. Keep your eyes and ears open and see what ideas come out of there, because that's where all of the sexy stuff is at the moment, at least that I've come across.
That's really reflective thing to think about there, I think, Matt, just how far behind research can be of actually what's happening in the trusts. Lisa, do you have any reflections to share?
Yeah, absolutely. Yeah, it's I think the danger of working so rapidly is that we end up knowing what happened but not how it happened. And then we can end up filling in the gaps as decision makers, or passing on those gaps to decision makers, and they fill it in with their own experience. And if we know anything, it's that the experience of those people whose voices haven't been heard as much can be very different. So we can end up making assumptions about what the how is like, because we've only got information on the what happened. So that would be my challenge, is to always make sure that we're making some attempt to raise those voices, to help decision makers understand what it is that means there's a health inequality. What was it? What experiences are different? What assumptions are different? And be able to give people more useful information on how that might be resolved and challenged. Because otherwise, as health services and as decision makers, they're perpetuating inequality. We don't have neutral decisions here. We're either helping challenge it or we're perpetuating it. So yeah, that would be my understanding of what's important there.
Really interesting. We've got one last question from Chris Sherlow-Johnson from Nuffield Trust, who asks, is there a different set of questions to be answered under a rapid evaluation? Less does this work than how can this work? Or what do we need to be seeing quantitative and qualitatively for this to work?
I would say that's really why theory-based evaluation is so popular in rapid cycle evaluation. Is it gets it really into the specifics of who's winning and losing, when is it happening, where is it happening, what mechanisms make it happen. And I think those theory-based questions are where we need to be at. We might not be able to answer all of them within the timescales we're working to, but that should be our aim, is to look through those types of questions and try and understand as best we can how it's happening.
It's really interesting. Okay, well, I think we will close the session. A huge thank you to Matt and Lucy for some really interesting discussion and really great presentations. And look forward to seeing how your work develops, Matt, in the future, and very mindful of the personal toll on rapid evaluation for evaluators and clinicians, as we've been discussing a little bit today.
Thank you.
So thank you for everyone who sent questions today. We've really appreciated those. The session is now having a little 10-minute break for you to have some refreshments and a little bit of a break. And we'll be back at 10:40, and John Sussex will be chairing a session then, which we look forward to very much. So thank you all for your time today, and look forward to seeing you a little bit later.